of periconception and embryonic health on future child and adult disease risks. To know that embryonic growth and development differs between pregnancies and between women. To apprehend the importance of non-medical risks as those related to poverty in association with adverse pregnancy outcomes. To understand a holistic approach to pregnancy-related care, crossing medical and social domains. To understand the importance of preconception care and to be able to name its main themes of content. And to realize the opportunities of M-Health applied periconceptionally to improve fertility and to decrease lifestyle and NCD risks. As laid out by the previous speakers, we know that the growth and development of the fetus in the second half of pregnancy is extremely important for the health of the newborn, but not only that, also for the health of future generations. And as you know, when a child is being born small for gestational age or prematurely, the risks of diabetes and cardiovascular disease in later life are substantially increased. And in discussing these themes, we often use perinatal mortality rates, and I think that's a very important measure of quality of care and of perinatal health. But we always have to realize that it's the tip of the iceberg of perinatal morbidity, being especially small for gestational age, fetal growth restriction, and prematurity. But we now know that not only the second half of pregnancy during fetal development, but also in early pregnancy and even the period before pregnancy during the gametogenesis, that this early periconception period is very important for the health of the newborn, but also for the health in later life. And again, so we define the periconception period as the period of gametogenesis, the previous 14 weeks before conception, and the first 10 weeks of pregnancy in which the main development of the embryo and the early placentation takes place. And so what I think a new theme should be discussed more often also in this Congress, and that's what I call embryonic health. And in a way, we have to shift the DOAT paradigm from the second half of pregnancy, in which all the Barker studies were done, to early pregnancy and even to the period of the preconception period. And in Rotterdam, in my department, we've got the availability of 2 large cohorts enabling to study this period. That's first of all the Rotterdam periconception cohort, the PREDICT study, in which women are being included in a study before pregnancy and then being followed in detail during the first weeks of pregnancy also by ultrasound. And the large Generation R study, which is a study in Rotterdam, a population-based study in which 10,000 pregnancies were followed. And those children and mothers are being followed now, first of all at 6 years of age, then at 9 years of age, and we're now in the middle of the follow-up program of 12 to 13 years of age. And again, we're seeing both the children and the mothers at our center. And one of the most important results of these both cohort studies is that we found out, but not only we, also other people internationally, that the assumption that embryonic growth is the same in all women and in all pregnancy is simply not true. Embryonic growth is not uniform. And if you summarize all those results, we found out that the embryo is larger depending on the sex of the embryo. In the case of a male embryo, the embryo is larger. And very interestingly also, when the mother is getting older, the embryo is getting larger as well. If there's a relatively high paternal rate, birth rate, the embryo was bigger. Women of black ethnic origin have larger embryos. And also we found that when a woman uses a relatively energy-rich diet, the embryo is bigger as well. Embryos are smaller in case women smoke, in case women take alcohol, in case women have a relatively high blood pressure, when they are relatively hemoconcentrated and when they are not taking folic acid. And a lot of people say, well, does it really matter when an embryo is relatively small? And it does. We know that when an embryo is relatively small, there's an increased risk of aneuploidy, an increased risk of miscarriage, an increased risk of being born with a low birth weight, being born small for gestational age, and also being born prematurely. And very importantly, quite recently in the Generation R study, we found that when you follow up those relatively small embryos, those children at the age of 6 years have already an increased higher total fat percentage, a higher diastolic blood pressure, and a higher total cholesterol levels. So embryonic size, embryonic growth really does matter. So I believe that in the next couple of years it will be increasingly important to study embryonic morphogenesis as well. Not only look at embryonic growth, but also look at embryonic morphogenesis. Because apparently there's an immensely big embryonic development plasticity, depending on all kinds of environmental factors, such as those related to the lifestyle. And in Rotterdam, we are able to do all kinds of detailed ultrasound studies early in pregnancy, obviously using 3D ultrasound. But normally the problem with 3D ultrasound is that you make 3D images, but you can only look at those images in a 2D manner, for example on paper or on a computer screen. And now we are able to use virtual reality to really enable to use that third dimension. And we do that in what we call the iSpace, which is a three-dimensional projection system in which a free-floating hologram is being created by a program which is called VScope. So now we are able to visualize an embryo of 2 to 3 centimeters enlarged like this, floating in a dark room. And I can show you this on the next short film. So this is an embryo in the iSpace of about 3 centimeters of 9 weeks. And you can see that you can look in big detail on the embryo. You can go through it and look at all kinds of anatomical details, for example, the brain ventricles. And you can even do automated measurements of those brain ventricles. We can also do automated measurements of the volume of the embryo and really look at morphogenesis. So you can also isolate the anatomic structures you want to study. And that enables you to get a real good insight also in the anatomy of the embryo. So you're looking here at the 3rd and 4th ventricles of the embryo. So, and that's what we're doing now in Rotterdam, that we're really looking at Carnegie stages, because the iSpace enables us to look in vivo at human embryonic Carnegie stages. And our first results show that, for example, when women smoke or when women use alcohol, that those morphologic development is delayed for a couple of days or even a week. We will present those results, I think, within a year, but to be honest, I think that's really exciting. So the periconception period is extremely important. The next thing we found out that the success of and the risks of the periconception period are not only depending on medical risks, but also very much are dependent on non-medical social risks. And we found out because we looked at our city of Rotterdam in detail on a neighborhood level. And when you look at urban perinatal health, in this case it is perinatal mortality, but I can show you the same pictures regarding perinatal prematurity or fetal growth restriction, you see an enormous disparity in our city between neighborhoods. The darker the color, the higher the perinatal mortality rate. And to be honest, I was quite scared when I found out, because there are some neighborhoods in Rotterdam with the darkest colors which have perinatal mortality rates of about 40 per 1,000 children born. 40. And that's a figure which is currently nationally true for a city like, or a country like Albania. So I always say my city is a kind of Albania at the Maas. The Maas is the river going through our city. So it's up to 4 to 5 times increased as compared to our national level of perinatal mortality. So that's another important message, I think. We should not only focus on national perinatal mortality figures, but we should look at perinatal morbidity figures, and we also should look at disparities in perinatal morbidity figures. And the other thing we found out, because everybody said, well, we know what the cause is, that will be the immigrant populations. But that was not true. The biggest risks of poverty in those deprived neighborhoods applied to the non-immigrant Western Rotterdam women. So they were at the highest risks of the adverse effects of poverty on pregnancy outcomes. So it's not only ethnicity related, but it's very importantly an issue of urban socio-economic deprivation. And I found what I think was an excellent film on YouTube of Larry Wallach of the Portland State University, explaining the importance of the social environment on pregnancies.
You look out at a city and you think about the access to public parks, access to public libraries, access to public goods. These are all things that affect the quality of life. And we now know that the quality of life directly affects how our genes operate. Your zip code may be more important to your health than your genetic code. We used to think chronic diseases like heart disease, diabetes, some cancers, were really a product of the genes you inherited and the lifestyle choices you made as you were getting older. What epigenetics tells us is that these diseases, rather than starting later in life, actually occur at the earliest stages of development and probably even in the previous generation. People are being born into this world at fundamental disadvantage that actually increases over time as a result of interaction with hostile environments. It's not biological determinism. It's about risk. And what we know is that risk that somebody comes into the world with is either reduced or increased by the environments they come in contact with. This is not just a health problem, but this is a much broader social equity issue. I'm interested in what the best zip code in the state of Oregon looks like. Strong neighborhood connections, strong schools, access to parks, access to affordable, healthy food. Many communities don't get these things, and now we know that through no choice of their own, by not having access to just these public goods, their health is being put at risk.
So again, I mean, providing preconception care, but also antenatal care, should not only focus on medical risks. It should also combine that care with looking at social risks. So I really believe that we should apply a much more holistic approach to pregnancy-related care, in which you should organize that the medical domain is being crossed with the social domain. And I really think you should do that by adopting a real life course health approach, and not doing that by healthcare providers only, but you have to do that together with municipalities and social welfare services. So for example, in Rotterdam now we've got a large program going on in which in taking care of those most vulnerable women in those deprived neighborhoods, we provide care together with the municipality, also looking at social risks and helping people to deal with it. For example, when they are in debt or when they are in housing problems, we help them in creating solutions, taking them by the hand. And in the end, that will also improve embryonic health, and I think that's what it should be about, to prevent what we call the poverty trap, as my previous speaker alluded to as well. The only way to prevent the poverty trap is to help people in the current pregnancies also with their social, economic problems. And when embryonic health is that important, obviously we should all provide preconception care as well, because otherwise we're just simply too late. Current antenatal care starts at, well, sometimes 8 weeks, but often much later than that. And then those very important early weeks of early placentation and embryogenesis are already past. Preconception care. And we had a Dutch summit on preconception care to get agreement on the definition, and we define preconception care as a set of interventions and or programs that aims to identify and enable informed decision making to modify biomedical, behavioral and psychosocial risks to parental health and to the health of their future child through counseling, prevention and management, emphasizing those factors that must be acted on before conception or early in pregnancy to have maximal impact and or choice. And obviously, you know, preconception care can be divided in a couple of themes. First of all, risk selection, look at the medical history, the obstetrical history, look at infections, previous birth defects in the family. Obviously, very important, quality of nutrition, already mentioned. I'll come back to that. Smoking, the use of alcohol, medication and drugs. And then you're able to provide all kind of information. Also nutritional recommendations. But I think also very important to already talk about the possibilities of prenatal screening and diagnosis. So when they get pregnant, normally they have only a couple of days or a week to think things through. But if you provide those information before pregnancy, people can make much more informed decisions on that subject as well. Interventions, well, obviously folic acid supplementation. Treatment of infections, vaccinations, very important as well. Offer them stop smoking programs, offer them dietary advice, also to reduce overweight. And when there are chronic diseases, we call that in Holland, you have to provide them specialist preconception care. And in special preconception care, obviously, a couple of questions are very important. What is the influence of the disease on the course of pregnancy? What's the influence of the pregnancy on the course of the disease, the other way around? What are the risks of surgical interventions, the risks of medication? What are the recurrence risks of previous obstetric complications? And what are the implications, for example, when you had severe preeclampsia? And obviously, at the end, you have to provide a clear management plan, also in writing, which is sent to all the other healthcare providers and I think to the couple themselves as well, so that everybody knows what the plan is when they do get pregnant. Preconception period is important and there are a lot of lifestyle risks. In my city of Rotterdam, when you look at the reproductive population, over 80% has malnutrition, poor nutrition. So they are not eating, they're especially eating too much, but not the good stuff. A lot of smoking, a very lot of social alcohol use, and a lot of people are obese. And it was also in the discussion, what should you do to help them? Because I really believe that you should take them by the hand. And when you, for example, look at nutrition, we looked not only at micro and micronutrients, but we also looked at dietary patterns. And those were striking results in the Generation R and the PREDICT study. For example, when you have a diet which resembles a Mediterranean diet, you have a 40% increased risk of a chance, positive chance of getting pregnant, a substantially decreased risk of getting a baby small for gestational age, a very decreased risk of a child with a spina bifida, independent of folic acid supplementation, and a substantially decreased risk of congenital heart defect, only by having a healthy Mediterranean diet. The other way around, when you have an unhealthy diet, which we call a McDonald's diet, for example, there's an increased risk of having a child with orofacial clefts. So nutrition really does matter. And I think it will be even more important in the future. And I really believe when you put the evidence together that there's a lot of information on lifestyle which really determines that those risk factors are real. The only problem is how to deal with that in the sense that you offer programs of intervention which are effective. And I think that's at the moment is the biggest question. And that's why we're in Holland doing a very large study in 14 municipalities to look at the way you should organize preconception care and to look at which programs are effective in helping people to adjust their preconception lifestyle. And because you should not only tell them that what they are doing is wrong. You should tell them that they should stop smoking, but then also tell them that after 2 days they can go to a certain practice which helps them to quit smoking. The same for dietary advice. Not only tell them that they should eat differently, but you have to offer them a program of intervention to keep on helping them. I think that's very, very important. And the use of tools can be very effective in that. In Holland we've got a national tool which is on a website which is called Preparing for Pregnancy, in which people at their homes can look through all kinds of questions and in a nice way identify risk factors for themselves, but also get information on why it is a risk factor and what they can do about it. And at the end there's a summary of risks which can be printed and be taken to the midwife or general practitioner or obstetrician to get preconception advice. But it's also a research tool, and again it's being used very, very commonly. It reaches almost 100,000 women every year, and we had already 1 million users since the start in 2004. Again, the information can be used for research after informed consent. And I really hope that within a year it can be linked with our national perinatal mortality registry so that we can link preconception risk factors with the outcome of pregnancy as well. What it does show, among other things, is that all women show preconception risk factors with a median of 5. And you can identify different risk profiles. Risks are highest in women older than 36 years of age, are highest among non-Western women, among women living in urban areas, and especially those in deprived neighborhoods, as I already showed you. So this tool, this instrument also enables tailored preconception care. And the other instrument which was developed in my department is being called Smarter Pregnancy, and that's a program for the mobile phone. And it not only in a very nice, friendly way identifies risk factors, but it also coaches people during 24 weeks in helping to adjust their lifestyles. And again, in a friendly way. For example, giving positive remarks when things are going better, giving them very nice cook recipes, giving SMS messages that they can pick up and take oranges for free at some supermarkets, because we have all kinds of deals with supermarkets in our country. And in a way that it should be a very nice instrument to use. I'll show you the first results, observational results, which were recently published. And when you look at, for example, vegetable intake from the moment people start using this program, you see that there's a substantial improvement in this case, the use of vegetables. And the interesting thing is when you look at the green line, that the results are always better in case also the husband participates. So when the couple participates together, the results are best also for the woman. Well, the same is true for fruits, a substantial increase, folic acid supplementation, stop smoking, and the decrease or quitting of alcohol use. And at the moment we currently are doing 2 randomized trials, one in a subfertile population in IVF clinics and one in the general population in Holland. And in that observational studies we were also able to look at risks and the chance of getting pregnant spontaneously. And for example, when you have a baseline risk score of 6, which means that you still are not taking vegetables enough and you're still using alcohol, And you compare that at the end of the coaching period, when you still have that risk factor, then there's the chance of spontaneous pregnancy of 25% in the fertile group and 9% in the subfertile group. But when you see when the risk profile decreases, so better people are really adjusting their lifestyle, you see that the chances of spontaneous pregnancy are substantially increases, up to even 48% in the fertile group and 21% in the subfertile group. So we really think this program can be very successful and especially helpful in helping people to adjust their lifestyle. So mHealth, we think, can improve periconception lifestyle. Obviously, we have to wait for the randomized trials as well. And very interestingly, participation of the male increases the improvement of the woman. And we show that improvement of lifestyle is associated with improved fertility in fertile and subfertile couples. And we're also internationally collaborating with a lot of centers in which this program is adapted for the national and local populations, and they're running randomized controlled trials as well. And when you're interested, please reply to this email address if you want to collaborate on this topic. So in conclusion, I really think that the new insights in the importance of the periconception period opens up a real new theme of what we call periconception and embryonic medicine. And in being able to understand much better the fetal but also the neonatal consequences of poor placentational and abnormal embryogenesis, I really think that we really will be able to improve perinatal health and therefore pregnancy outcome, but also the health of future generations. And that's why this topic is now the main research as well as clinical theme in my department, and that's why we made a little film about it.
Shaping the health of future generations implies pre-pregnancy health and preconception care. The first 10 weeks of embryonic growth are crucial for determining the outcome of pregnancy. Being relatively small as an embryo is associated with an increased risk of being born small for gestational age and an adverse cardiovascular risk profile at 6 years of age. Therefore, embryonic growth and development shapes the health of an individual, not only at birth, but also later in life. Risks for abnormal embryonic development are a low intake of folic acid, vegetables, fruits and fish. The most harmful lifestyle choices are smoking and alcohol consumption. To avoid these risks and improve the health of future generations, care tailored to the couple's situation should be provided before pregnancy in order to be effective. Embryonic health is related to fetal growth and development during the second half of pregnancy. Management of fetal care is therefore a continuum with embryonic health. This requires a multidisciplinary approach by obstetricians and neonatologists. For example, by means of perinatal review meetings. Neonatal care and treatment simulates the perfect intrauterine conditions, catering to the needs and vulnerability of critically ill infants. Infants are not just being kept alive, they are being helped to grow and develop as they would inside a healthy mother's womb, reducing the risk for future diseases. Kangaroo parental care is provided to improve babies' chances and to make sure that parents get the opportunity to bond with their babies. The preconception program of the Departments of Obstetrics, Prenatal Medicine and Neonatology at the Erasmus MC in Rotterdam aim to prevent subfertility and adverse pregnancy outcomes by improving general health, nutrition and lifestyle when couples are trying to conceive, thereby optimizing embryonic health and enabling individualized fetal and neonatal care. The health of future generations. From pre-pregnancy care to embryonic health, a healthy child, a healthy adult, and pregnancies in subsequent generations.
And finally, I want to thank my group who is doing all the work. Thank you for your attention.
So thank you very much for that really challenging presentation. I'm sure there's lots of questions. So if I just ask, first of all, sort of as a Europe-wide, how do you fund preconceptual care? So in the UK, the problem is it falls between the sort of primary care sector and the secondary care sector. So how have you overcome that problem in Netherlands?
Well, it's a problem in Holland as well. The preconception care is being funded by the regular healthcare insurance companies for the general practitioners, but not for the midwives. So at the moment, in all those cities in which we're doing the healthy pregnancy for all study, in the 40 municipalities, there is a money provided by the Ministry of Health for the duration of the project. And we hope that by the results of the project, then the healthcare insurance companies will start to pay. But it's a problem as well. For the obstetricians, it's no problem because there is a regular fee for that, for specialist preconception care.
So what about in other countries? Is anybody able to say how, if preconceptual care, would you mind, Mary, saying what happens in the States? Do they fund preconceptual care in the United States? Or?
Yes, in the US they do. We recommend that, for example, recurrent pregnancy loss patients are seen prior to conception to talk about preconception care. And yes, so it is available.
What about in Japan? There's some people from Japan. Would you like to ask a question? Then could you tell us how they fund preconceptual care in Japan as well? Yeah. Would you like to say? Yeah.
Okay. Thank you very much. This was one of the best talks I've ever heard. Thank you so much for that. We have been following your web pages and we have been very enthusiastic here in Helsinki at my clinic Felicitas for the periconceptional work, and we have done that for some 7 years. We started with infertility patients coming from other clinics, trying to diagnosticize their problems, having had several IVFs without any good result, and then we found out that there are developing diseases behind their condition. Some of them got pregnant spontaneously, like patients with celiakia. They had not had their diagnosis workout done. And thereafter, we started to look at patients who, after 1 year of infertility, came into the clinic and started to practice along your guidelines, just in a very small setting. 50% of these people came pregnant spontaneously, and currently we started with a preconceptional unit more than a year ago. And I think we should, concerning the funding, these patients come to see a doctor, so that is how the treatment is funded. But it just came to my mind with your talk that there are personal trainers in every gym. Should we have a personal trainer for a couple who wants to get pregnant, or could we kind of get use of this wonderful web program?
Sure.
Yeah, which you just presented.
Yeah.
I'm absolutely certain that we are going to be responsible in the future if we do neglect the periconceptional period. So thank you very much.
Thank you for the comment. Yes, I fully agree. I mean, I think that also in ART, IVF doctors should not only be responsible for getting those women pregnant, but they are also responsible for the health of that embryo after implantation.
Thank you, Eric. Mary Stevenson, University of Illinois. I've been following your work for some time, and I certainly have noticed preconception care, the importance of it in recurrent pregnancy loss. So I have two questions. Well, first of all, in the United States, I would suggest that patients are not prepared to wait 3 or 6 months to change their lifestyle. And so it's an ongoing battle. They want to come into the office, get that pill, and out the door. So how do you deal with that? Do you have a different type of patient?
Well, no, I recognize the same emotions among patients, but for the ART population, people are obliged to, first of all, we had a special outpatient clinic for lifestyle. And people would not be treated for IVF when they were not going to that outpatient clinic. Mm-hmm. Now it's the same for the Smarter Pregnancy program, so they should use the program, and otherwise they won't be treated. When they have chronic diseases, they first have to go to the specialist preconception outpatient clinic in our department. If they don't, they won't be treated. And if the obstetrician, before he has a complete final management plan in those women with chronic diseases, they will not be treated for IVF. So we are getting more and more strict when to treat. And when we think that a couple is not ready or are not using appropriate advice, we just don't treat them. Which is difficult, I agree.
That is quite a different system.
And the other thing is that people coming in for specialist preconception care, and it's very complicated because sometimes, well, you know, they have not one disease, they have 3 diseases, and they have 4 or 5 specialists for neurology, cardiology, clinical geneticists. It takes some time to get insights in what's going on and to make a good plan. And then I often advise them to go back on the contraceptive pill, for example, just to create time. And when you explain it to women, most of them will do that. But you have to create time, I agree. Yeah.
My second question is going back to the beginning of Generation R, where you reported your high mortality rates in various areas of Rotterdam. For follow-up now, have you been able to drastically improve those mortality rates?
Yeah, that's a good question. We're in the middle of that now, because you have to do that across a substantial couple of years, otherwise the numbers are too small. So the results I showed you now were from 2000 to 2008. We're just in the middle of analyzing 2008, 2015. And what I can tell you is that perinatal mortality substantially decreased, but perinatal morbidity doesn't. So the numbers of low birth rate and prematurity are hardly decreased. Mortality does, but morbidity does not. And in a way I think that's understandable, because the etiology of prematurity and low birth rates is obviously in the first trimester of pregnancy. And to be able to affect those risks is extremely difficult. And by knowing the social risks, I think midwives and obstetricians in the second half of pregnancy are more aware. So they're not dying anymore. We get those babies out alive. And those are the effects of the last years. But the real preventive effects of those morbidity figures are not realized as yet. No. And I think preconception care and early pregnancy care should improve furthermore to be able to do that. Yeah.
So your work is giving some answers, safe to our first presentation today, because the question is always, if you have an obese patient and she loses weight prior to attempting pregnancy, does it change anything? Does it change outcome? That's our big question.
Yeah,
we just can't assume
I can't tell you that.
Our
Our figures do show that when they lose weight, but you know, but even when they lose a little bit of weight, they more often get pregnant spontaneously.
Correct. Yeah.
That's a dramatic effect. Yeah. Whether the outcome in newborn health of later life is improved, I'm not sure. I can't tell you yet. No.
Yeah. Thank you.
I wondered if I could have some comments from the ethicists here or social scientists on this concept that if somebody was obese or on a poor diet, he wasn't going to offer them IVF or infertility treatment. Oh, you're going to talk about that later. Oh, so oh, good. That's going to be the after lunch discussion. I just wanted to. So there's a lot of people here from early pregnancy. So do you have any miscarriage rate data from your app yet? Does it affect
I'm sorry, I don't, and that's because our national perinatal registry does not include miscarriage figures. So I just can't tell you that. I know it's terrible, but I can't.
Are you collecting it?
Well, no, we're not at the moment, because the way we collect municipal and national figures is by the national registry.
Oh, I see.
And it's not included in that. So I would love to have those, yes.
Susan Bewley, obstetrician, thank you very much for your presentation, all music to my ears. I have a couple of questions which are to do with the unexpected findings of study. Can I just ask, was that data you showed about the improvement in outcome from RCTs, or was it before and after data?
Before and after data.
Okay.
Yeah, we're running now RCTs.
Excellent. Well, I wish you the best of luck with the RCTs. I'm very interested to hear that.
Sure.
In those, when you do the RCTs, I'm very interested also in the impact on the people who don't take up the coaching. I worry about whether coaching works on people who haven't been groomed into having pills, and whether you may see differences in anxiety levels going up, whether you have any differences in worse outcomes or increasing inequity. And the other question I have also about, very interested in the participation of males, because there are a subset of males who are sabotage and are not helpful to women, and that whether you see any adverse outcomes in relationships. So I'm interested in when it doesn't work, does it actually get worse?
I can't tell you yet, because the RCTs are running.
Are you looking for all those things in the RCTs?
Not all those things. So, for example, stress is not being measured as I recall, but it's a very good suggestion. Yeah.
Thank you very much for your presentation. So then in Japan, there is not many clinics and universities to give this such kind of preconception care. But in general, people who want to have baby know well known this information from the internet or some magazines for pregnancy. Then, but I think we need to have a guideline which number is good for example, alcohol or of course not smoking tobacco like that. Then I just want to ask you about the caffeine. So for being pregnant, the caffeine, too much caffeine is not good. We sometimes say it. So then do you have some information about it?
No. I know there's a lot of discussion also in the literature about caffeine intake and miscarriage rate and pregnancy outcome. We haven't included that in our studies now. No. What the first thing you said about women looking for information when they want to get pregnant, that's very interesting, because in Holland we see that when you provide information, people take it up. They look at folders, they look at internet, they really want to get a lot of information. But what they are not doing, or not often doing, is going for a preconception consultation with a midwife or a general practitioner. In Holland there's a kind of, how do you call it, there's a resistance in getting out to a care provider to talk about their wish to get pregnant. And whether that's a kind of privacy thing, or maybe Guido knows, but and all the studies we do show the same thing. People are very much interested in information, but are very, very reluctant to go to a midwife or general practitioner to talk about it and to get advice. And I'm not sure whether that's in other countries the same thing, but in Holland that's a problem.
Thank you very much.
Françoise Shenfield, University College London. To look at it in the societal environment, which you described wonderfully about the deprivation and non-deprivation, I think a similar subject is a very current topic in our specialty, which is reproductive aging, and how to explain to women and their partners that there is an ideal time to possibly not meet people like me because they haven't been pregnant after trying for a year or whatever. So for the first time, after we discussed it for a long time, the British Fertility Society is going to try to do a school information. Oh, right. And that's been a hobby horse of mine for a long, long time. I've always said we don't need to speak to the Department of Health, we need to speak to the Department of Education. And I think Holland has certainly, up till now, an excellent record on contraception. Yeah. The rate of termination of pregnancy for young people is certainly much lower than the rate that we've had in the UK. So you have a model, and the model would be ideally, what do you think? When you teach contraception, and when people come for contraception, of course they don't want to be pregnant now, but many people, perhaps even the majority, are planning a family. This is why there's the old name of family planning was used for that. So might it be, do you think, the ideal time to say, this is very good contraception now, but do remember, it may feel a long, long time for now. When you want to become pregnant, remember about non-smoking, remember about your diet, and the education, of course, is always repetition. So at school, then at university, then when you use contraception. And I think your GP system is very good. Where do you think that the failing is that there's still these pockets
Well,
of
you say
poverty.
it all. I fully agree. I think you should apply a multi-hit approach in telling people how to get pregnant in a healthy way. It fails because at school it fails because teachers think they cannot combine the message of adequate anticonception with the message of when you want to become pregnant in many years' time, you have to do it in a healthy way. There's a big reluctance among teachers to do that. When you ask students themselves, they say it's fine. I'm clever enough. I know the difference between anticonception and the moment I want to get pregnant. But teachers are very reluctant to do this. The other thing why it fails is that, for example, general practitioners, when they see women in reproductive age, well, a couple of times per year, they don't use that moment to tell them, gee, you're 28 years of age now, you come here because of your asthma problems, for example. But realize that when you want to become pregnant, we have to think about your medication, because we have to change your medication. It also fails with specialists, for example, neurologists. They see young women because they have epilepsy. They don't tell them when they are 24 years of age, well, you are very young, maybe you think about getting children. Realize that when you do, come back and we have to talk about your medication. And we have to change that. Or you have to go to an obstetrician to make a plan how to, well, how do your prenatal diagnosis and your ultrasound scans and things like that. It's being missed, and that's why it fails. So there has to be a change in mindset of all healthcare providers throughout the whole chain of pregnancy-related care.
Thank you.
Yeah, that's a good question. I think the government has a very... Yes, all of them, including the government, and the local government as well. So the local government in Rotterdam takes up that responsibility.
They walking volumes there. They don't care if you are 12 and
Well,
you need to take care of you 27.
Yeah, I know what you mean, but it's not complete. At least in Holland, it's not completely true. What I did was with the map, the neighborhood map of Rotterdam, I went to the municipality. And the woman who was responsible for the health of people in Rotterdam. And when I explained her not once but 10 times what perinatal mortality means, also with respect to as the tip of the iceberg of future health, then she said, Eric, now it's not only your problem, now it's my problem as well. And from then on, she and also her successors, because you're right, in politics they go and. But perinatal health is now a official municipal health issue in Rotterdam. So it's being reported on every 5 years, and policy is being made. So it is possible. But you have to explain it not once, you have to explain it 10 times. You have to be willing to go out of your university and go to the municipalities, go to the neighborhoods, go to the Ministry of Health. And then you achieve something. At least in Holland it works. But it's difficult, I know.
Well, thank you very much, everyone, for a really good introduction to this day. So we've now got half an hour coffee break, and then after the coffee break, we're going to discuss the much broader implications of the exciting information we've had this morning. So thanks very much, and please carry on joining in these debates.